Good morning, everybody, and thank you, Dr. Pradeep sir, for having me at this instruction course. I'm sure each one of us does a trabeculectomy, and the next morning we think everything's fine. But that's where the story starts, and you have to manage the bleb, as Manish just pointed out. It's like a child, and you have to see it grow in front of your eyes. So, but though we talk about bleb failure and we always look at the post-operative part of it, but equally important is you need to identify and treat pre-operative risk factors. You need to avoid intraoperative risk factors and ultimately manage the post-operative risk factors. The most common pre-operative risk factors is the multiple medications which we put our patients on, and this study has proven, as compared to in the olden days where we just had timolol and pilocarpine, the bleb survival was much better with 1 or 2 medications as compared to nowadays where we have 4 or more medications. That's all because the conjunctival cell morphology changes with excess use of preservative-containing anti-glaucoma medications. Also, when you plan a trabeculectomy, please look at the anterior segment very well, because you could have these presenting risk factors. The first patient could be a patient of Sturge-Weber. You have extensive episcleral blood vessels, and you know these patients cause a lot of episcleral scarring, and hence you might plan probably implant as George just told. You could have a patient with extensive just conjunctival scarring following a vitrectomy or following a retinal surgery. You could have a patient with uveitis. So a patient with high intraocular pressure with active uveitis, please don't go ahead and do a trab. First treat the uveitis, make the eye quiet, and only then your trab will succeed. You could have a patient with vitreous in the anterior segment. So you have to do a vitrectomy, just not the trabeculectomy, because that could be the inflammatory factor which could cause bleb failure. ICE syndrome again is known to have a high risk of bleb failure. You could have a patient with fibrovascular ingrowth or a neovascular glaucoma. These are all risk factors which you need to identify before you plan your trabeculectomy or whether not to do a trabeculectomy. Intraoperative risk factors are equally important. You could have extensive subconjunctival hemorrhage, because this causes a lot of prostaglandin release and causes vascularization postoperatively. Inadequate suturing. You could have a scleral flap suture which is protruding through the conjunctiva, which acts as a nidus and invites vascularization, resulting in early bleb failure. Or a bad conjunctival suturing is also an invitation for bleb failure. You could have a vitreous in anterior chamber, where probably because of high intraocular pressure intraoperatively and you've done a iridectomy, the vitreous presence out there sometimes, and that could cause internal ostium blockage. Such. Coming to post-operative management would depend on the timing of the pressure rise. So if it's usually in the first month, it's categorized as early bleb failure. If it's after a month, it's a late bleb failure. Also, you need to know the site of the aqueous obstruction. So this is a flow chart that when you have done a trabeculectomy and post-operative day 1 onwards, please assess your bleb, please assess your anterior chamber depth and the intraocular pressure. So coming to the first situation where the chamber is deep in presence of a raised intraocular pressure. Now depending when the patient presents to you, if it's immediate post-op, the most common cause is a tight flap closure or obstruction of the internal ostium. If the pressures were doing fine and it's after 2 weeks or something that the pressure starts rising, the most common cause is a Tenon cyst formation. And if pressures are fine for a month or more and then the pressure starts rising, it's the bleb vascularization and bleb failure which is occurring. So taking each one individually, how would you identify whether the internal ostium gets obstructed? The most common cause of internal ostium obstruction is usually the peripheral iris. And if you've not done an iridectomy or not done an adequate iridectomy, the pillars of the iris could go in and block the internal ostium. And how would you see it post-operatively? The first thing on post-op day 1, you will see this peaking of the pupil. And as soon as you see this peaking, just put in a gonioscope and that confirms that your internal ostium is getting obstructed, and that's what is causing the rise in pressure. So put the patient on pilocarpine, constrict the pupil, and if it does not help you, you might have to do a YAG laser or argon laser iridoplasty out there and release the peripheral iris. Rare cases, if you've done a 2 anterior dissection of a trabeculectomy, your descemetes could detach and that could curl up and cause the internal ostium block. So all you could do is use a YAG laser and just release that obstruction. If there is a tight flap closure, so because the flap is tight, the aqueous is not egressing out. So you would have a flat bleb, the pressure is high, and the chamber is deep as such. And on gonioscopy, there would not be any internal ostium obstruction. So what would you do? First step would be a massage, which we all are aware of. So this is a massage what we normally follow. Let the patient look up and on the lower aspect, just press the sclera and the bleb gets elevated. What I usually follow is a more safer procedure, is tell the patient to look down, and on slit lamp, without he being aware what you're trying to do, is you press the posterior scleral lip, and as soon as you press, the aqueous egresses out. That helps in two ways. One, it's a more controlled elevation because you're actually seeing the bleb forming right in front of you, so not too much of excessive pressure, and this will not cause a flattening of the chamber. And secondly, when you're pressing it, you get an idea of the degree of resistance you're getting. So if the resistance is quite high, that means your sutures are very tight, and you would have to consider a laser suture lysis as such. If the pressure continues to remain elevated in spite of a massage, you would do a laser suture lysis or remove the releasable suture if you've taken one. Now, laser suture lysis has certain disadvantages because you need to visualize the suture when you're doing a laser suture lysis. So if there's a thick tenons or extensive hemorrhage, you may not be able to visualize it. And sometimes if you focus the laser on the conjunctival wound leak can occur. And because you're pressing the lens against the sclera while you're doing the laser suture lysis, sometimes sudden gushing can cause a flattening of the chamber. So I usually prefer the releasable suture because it does not require an access to an organ laser or any of the lens, and is independent of a subconjunctival suture visualization. And this is as a simple technique as like a normal suture removal. Let the patient look down, and the knot, basically this is the loop which is over the cornea. Just pull it down, and the the suture gets released. And this is how the bleb would appear elevated after you release the suture. Whether you're doing laser suture lysis or suture removal, one suture per session, because otherwise it can cause excessive hypotony sometimes. Coming to the next differential diagnosis, a Tenon cyst, and this is a phacotrap which I had done, and 2 weeks later I got this pearly cyst formation. Internal ostium, there was no obstruction, and the pressure starts getting elevated. So how would you go about it? First thing, immediately would remove the releasable suture, massage the bleb, teach the patient to taper the topical prednisolone, because sometimes there could be some amount of steroid response also adding to the pressure rise, and follow up the patients. And if the pressure is not controlled, you might have to reinitiate medical therapy in a stepwise manner, and you could continue with milder steroids and digital massage. And should the conservative management fail, and if the pressures are very high, you might have to do a needling or excision of the cyst as such. Now, usually we associate the bleb failure with a raised intraocular pressure, but there could be a situation where the patient presents to you with a low intraocular pressure and a hypotony, and that could lead to a bleb failure. As in this patient, the patient had undergone a trabeculectomy elsewhere, and patient presented to us with low pressures and a flat chamber, and actually the wound had leaked out here, and the conjunctiva basically had given way, and this was Seedles positive. And we immediately sutured the patient up, and the bleb could be retrieved. If this would have continued to occur, the bleb would have surely failed. So it's not always raised pressure that the patient might present to you with. There could be a hypotony which ultimately might lead to bleb failure. So these are the signs you would look at for early signs of failing bleb. You would see increased vascularity and increasing opacity of the subconjunctival tissues, and there's a decreased conjunctival mobility, and the bleb starts localizing and ultimately flattens down. Management options: once the bleb starts you feel it's an early stage, you reinitiate the medical therapy because the pressures are high and you have to reduce the pressure, and you might give these subconjunctival injections to reduce the vascularization, injection 5-FU or injection MMC subconjunctival. They are not effective if the bleb flattens as such. I usually prefer injection 5-FU. And there are different techniques of giving it. The textbook describes it to give it 180 degrees away, but we've been giving posterior to the bleb, and with the patient looking down using topical paracaine, using a 30 gauge needle, a 0.1 ml is injected posterior to the bleb. Now if the bleb flattens or if the pressure remains uncontrolled, then you might have to consider needling of the bleb, or ultimately repeat the trabeculectomy, or even consider a glaucoma implant. Now needling can be performed on slit lamp or in operation theatre. I prefer it in the OT. Using topical or local anesthesia, I prefer the local anesthesia because it gives a good comfort when you're doing a needling. Always instill phenylephrine to constrict the blood vessels, so your bleb, the scleral flap edges are more prominent. I always use a 25 gauge needle, unlike what is described as 26 gauge needle, because 25 gauge needle is a thicker needle. It's a 1-inch needle, so I can go quite far away from the main area of the bleb, and because it's a thicker needle, it gives me a good leverage to cut the subconjunctival fibrosis and also go under the scleral flap as such. And this is the technique basically. As you can see, this is your scleral flap. So once you enter the subconjunctival space, I always first try to open the subscleral space and go into the anterior chamber also, and then do the subconjunctival dissection, because if you do the subconjunctival dissection and it bleeds, you won't be able to visualize your scleral flap. So always go behind the scleral flap first, finish off that dissection, and then go to the subconjunctival dissection as such. Now, if the needling also fails, you might have to consider trab with mitomycin or a glaucoma implant. So the failure of a trab can be prevented by identification and treating pre-operative risk factors, avoiding any intraoperative risk factors, and ultimately manage the bleb post-operatively. So early detection and intervention is very important. Thank you.